Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's December 2022 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. The Editor's Choice this month is an original article entitled Changes in Burnout and Satisfaction with Work-Life Integration in Physicians During the First 2 Years of the COVID-19 Pandemic. It is authored by Dr. Tate Shanafelt from Stanford University in Palo Alto, California, and colleagues from Mayo Clinic in Rochester, Minnesota, the University of Colorado School of Medicine in Denver, Colorado, and the American Medical Association in Chicago, Illinois. Shanafelt et al. Assessed the effects of the COVID-19 pandemic on physicians' burnout by surveying U.S. physicians between December 2021 and January 2022, some 21 months after the beginning of the pandemic. For well over a decade preceding this survey, Shanafelt and colleagues have pioneered the study of physician burnout by recognizing and bringing this phenomenon to medical and public attention, by elucidating its characteristics, causes, and consequences, and by delineating novel strategies that may reduce the occurrence of burnout and the severity of its impact. In their present study, these investigators drew upon their triennial surveys of physician burnout and satisfaction with work-life integration, which they began in 2011. Their current survey, involving almost 2,500 physicians, revealed that scores for emotional exhaustion and depersonalization markedly increased in the 2021 survey compared with the 2020 and were higher than all of the prior triennial surveys undertaken in 2020, 2017, 2014, and 2011. For example, compared with the 2020 survey, mean scores for emotional exhaustion and depersonalization in the 2021 survey increased by more than 38% and 60% respectively, while over this time frame the prevalence of physicians with at least one characteristic of burnout increased by approximately 25%. Satisfaction with work-life integration in 2021 significantly declined to approximately 30% from 46% in 2020. This marked increase in burnout and decrease in satisfaction with work-life integration markedly outstripped the increase in depression, 6.1% over this time period, leading the authors to conclude that the increase in physician distress was work-related. Practitioners in certain specialties, emergency medicine, general pediatrics, and family medicine, and female physicians were all at a higher risk for burnout in 2021. Interestingly, a mild mitigation in burnout and an increase in satisfaction and work-life integration occurred at the overall physician population level in 2020 compared to 2017, which, as suggested by the authors, reflected in part a temporary amelioration during the early days of the pandemic of some types of stressors that are known to underpin burnout for physicians outside the early pandemic hotspots. However, as the COVID-19 pandemic widely and deeply enveloped the United States and the world, imposing its well-recognized stresses on and exposing the deficiencies and fissures in the delivery of healthcare in the United States, the result was the worsening burnout and declining satisfaction in work-life integration as observed in the present study. These alarming findings, as underscored by Shanafelt et al., have profound ramifications for the U.S. healthcare system. One hopes that these findings do not reflect a new heightened, essentially unyielding baseline level for physician burnout, but rather a modifiable level that will subside strikingly below its pre-pandemic levels, especially as the pandemic and its attendant burdens abate and as initiatives to combat burnout prove increasingly effective. Our first highlight this month is an original article entitled Urinary Sodium to Potassium Ratio and Incident Chronic Kidney Disease, Results from the Korean Genome and Epidemiology Study. It is authored by Dr. Young Soo Jo and colleagues from Yonsei University in Seoul, Republic of Korea. Increased sodium intake has long been linked to hypertension, and less consistently so to chronic kidney disease. Conversely, while hyperkalemia is to be avoided and/or treated because of its arrhythmogenic effects, there is clear evidence that increased dietary intake of potassium reduces the risk of cardiovascular disease, hypertension, and even chronic kidney disease. This salutary effect of increased dietary potassium intake may reflect, at least in part, the attendant increase in sodium excretion by the kidney. In addition to assessing the effects of dietary intake of sodium and potassium, independent of each other, in such diseases, an evolving concept emphasizes that dietary intake of each electrolyte, as reflected by the urinary sodium to potassium ratio, should also be considered. Using data from the Korean Genome and Epidemiology Study, Zhou et al. Studied whether the urinary sodium to potassium ratio associates with incident chronic kidney disease. These investigators determined the urinary sodium to potassium ratio in participants with normal kidney function at the time of enrollment between June 1, 2001 and January 31, 2003, and evaluated the occurrence of chronic kidney disease during follow-up until December 31, 2016. The findings demonstrate that incident chronic kidney disease was significantly lower in participants whose urinary sodium to potassium ratio was in the lowest tertile compared to those with the ratio in the highest tertile. When the urinary sodium to potassium ratio was considered as a continuous variable, as this ratio increased, so did incident chronic kidney disease. In contrast, there was no significant association with either 24-hour urinary sodium excretion or 24-hour urinary potassium excretion. To explain these findings, the authors considered whether hypertension was the intermediary between urinary sodium to potassium ratio and chronic kidney disease. However, this appeared unlikely, as the association between this ratio and chronic kidney disease persisted even after adjustment for hypertension, while the prevalence of hypertension was comparable across the three tertiles. Another possible explanation suggested by the authors relates to the previously described association between increased urinary sodium to potassium ratio and insulin resistance, and between this ratio and obesity. The authors emphasized the need for confirmatory studies, including in other ethnicities. These intriguing findings of Zhou et al. Add to the growing evidence regarding the pathogenetic significance of the relative and not just absolute intake of these electrolytes. Our second highlight this month is an original article entitled Sudden Cardiac Death in Patients with Type 1 versus Type 2 Diabetes. It is authored by Dr. Faye Norby from the Schmid Heart Institute at Cedars-Sinai's Health System in Los Angeles, California, and colleagues from the Kaiser Permanente Center for Health Research in Portland, Oregon, and the Oregon Health and Science University, also in Portland, Oregon. Norby et al. Undertook a prospective community-based study of sudden cardiac arrest in 2,771 cases and 8,313 match controls, assessing the association of sudden cardiac arrest with both type 1 and type 2 diabetes. Significant differences exist in the pathogenesis of type 1 diabetes and type 2 diabetes, and in the rate at which and the severity with which complications develops in either condition. Yet no data are currently available regarding the relative risk of sudden cardiac arrest in type 1 diabetes and type 2 diabetes. The findings of Norby et al. Demonstrate that even after adjustment for relative risk factors, there was a 1.5-fold higher odds for sudden cardiac arrest in patients with diabetes, and that the odds increased approximately 2.5-fold in type 1 diabetes compared with type 2 diabetes. The authors point out that type 1 diabetes and type 2 diabetes are associated with various conditions, specifically obesity, hypertension, coronary artery disease, and heart failure, that all predispose to sudden cardiac arrest. However, such conditions could not be implicated in the observed differences in type 1 diabetes and type 2 diabetes, as their prevalence was similar in both groups. Interestingly, the prevalence of chronic kidney disease, a condition that itself predisposes to sudden cardiac arrest, was greater in type 1 diabetes compared with either patients with type 2 diabetes or in those without diabetes, thereby raising the possibility that greater chronic kidney disease may underlie the higher risk for sudden cardiac arrest in type 1 diabetes. The authors also point out that the similar or increased prevalence of the conditions listed above in type 1 diabetes, despite the younger age of patients with type 1 diabetes, speaks to the increased tempo with which such conditions develop in type 1 diabetes compared with type 2 diabetes. Furthermore, this study demonstrated that patients with type 1 diabetes as compared with type 2 diabetes were more likely to have an unwitnessed cardiac arrest, no attempts at resuscitation, and less survival. In addition to underscoring diabetes mellitus as a risk factor for sudden cardiac arrest, and in uncovering the novel observation that the risk for sudden cardiac arrest is greater in patients with type 1 diabetes as compared to type 2 diabetes, these important findings disclose the relevance of the type of diabetes in strategies that aim to prevention of sudden cardiac arrest. You can access these highlights and editor's choice articles free of charge during the entire month of December. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find links to our social media by clicking the buttons at the bottom of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insights podcast recordings, which are available from our website on our homepage as well as through iTunes. You will also find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content as well as articles published online in press. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.